Next up, we have a case presentation by Dr. Inya, a final year postgraduate from ICH. We request Professor Dr. Ravichandran Sir and Professor Dr. Hemachitra Ma'am to chair the session. Professor Dr. Ravichandran Sir is the Director of Institute of Social Pediatrics, Stanley Medical College, an avid reader who is always ready to impart knowledge to his students. Professor Dr. Hemachitra, Head of Department of Pediatrics, Kasturba Gandhi Hospital. Ma'am is known for her clinical acumen and bedside techniques.
Good afternoon, respected Professor. Good afternoon, ma'am. Good afternoon, sir. I am Dr. Ines Sangavi, final year postgraduate from ICH. Moving on to the case. My child is Master Austin. He is a 2 years and 9 months old child. His second born of non-consanguineous marriage, brought by mother with complaints of not attaining age-appropriate milestones since birth and complaints of seizure, one episode which is 1 week back. Since the history is dating back from the antenatal period, I would like to start my history from the antenatal events. This is second pregnancy, and regarding the first pregnancy, mother was married at 21 years and conceived 3 months after marriage. Antenatal period was uneventful and the mother delivered an alive and healthy baby via spontaneous normal vaginal delivery. Regarding this current pregnancy, mother conceived 2 years after first pregnancy. The pregnancy was confirmed by urine pregnancy test at 50 days. LMP was 26/9/2016 and EDD was 4/7/2017. The pregnancy was registered at a PHC near Kadalur, and the dating scan was not done at first trimester. There is no history of fever with rash, post-auricular swelling, there is no history of PET exposure or any drug intake. IFA was taken irregularly. There is no history of radiation exposure either. Regarding second trimester, the pregnancy was further followed at IOG. Quickening was felt at 5 months. Immunization was completed in second trimester. There is no history of PIH, GDM or anemia. First antenatal scan was done only in the second trimester and was said to be normal. Third trimester, there is no history of either decreased or increased fetal movements. There is no history of PROM. There is no history of foul-smelling liquor. There is no history of maternal fever or urinary tract symptoms, and there is no history suggestive of APH. During birth history, the mother delivered on 1/7/2017. Mother developed contractions around 11 p.m. and admitted at IOG and delivered spontaneously at 2 a.m. There is no history of prolonged second stage of labor. There is no history of instrumental delivery. Birth weight was 2 kgs. Child did not cry immediately after birth and required resuscitation, but the details of resuscitation and UPGAR was not available. Child was admitted into NICU. Regarding the events that happened in the postnatal period, mother breastfed the child 8 hours after birth and child was under level 2 care. Child developed respiratory distress on day 3 of life and shifted to level 3 care. Child required intubation and was on ventilator for about 30 days. Child started on tube feeds from day 11 of life. Child support was gradually stepped down and weaned off to room air after 30 days. Child was on prolonged IV medication and lumbar puncture was done during the course of stay. Child was shifted to mother's side after 30 days and discharged at 45 days of life. Poor sucking and hypotonia was noted by mother during the hospital stay. All these histories based on mother's history, and there is no written details was available along with her. Moving on to the developmental history, child did not attain head control. There is no midline hand play or reaching for objects. There is a child only recognizes mother at 4 months of life, and cooing was attained at 1 year. So the developmental age comes around 2 to 3 months, and the developmental quotient is 10.
From the history, what do you suspect? You have not examined the child. So.
Yes, sir. Still history of presenting.
Still it is there.
Yes.
So what was the duration of first stage of labor?
It was including first and second stage. It was only 3 hours, sir.
Is it possible in a priming?
It is multi, sir.
First pregnancy.
This is second.
Second. So even in second gravida.
It was mother developed pains at 11 p.m. sir, and she has come to IOG and delivered around 2 a.m. in the midnight.
So the timing is not reliable.
Okay. Getting history of presenting illness, history of stiffness involving all 4 limbs noted by mother since 3 months of age. History of crossing over of legs was present. History of difficulty in wearing diapers and cleaning the perineum. History of persistent fisting of hands noted by mother. And no history of yearly hand preference or no history of involuntary movements. History of seizure, which was 2 weeks back, for which child was admitted at ICH. It was generalized tonic-clonic type of seizure, which was lasted 5 to 10 minutes, and it was not preceded by fever. Child had seizure episode on and off from 4 months of age. Initially, child was started on single AEDs, and currently child is on 2 AEDs. History of incessant cry and irritability, sleep disturbances noted by mother since early infancy, and child able to recognize mother. History of difficulty in fixing and following toys, that is history of abnormal eye position. No history of deviation of angle of mouth. History of drooling of saliva present initially, not on any particular side. History of reduced response to sound. History of aspirations and difficulty in swallowing present. There is history of crying and irritability to wet diapers. Child cries for insect or mosquito bites. Bladder and bowel control not yet attained. There is history of sleep disturbances, history of poor weight gain, history of feeding difficulties. There is no history of bed sores, skin infections or contractures. Child was started on physiotherapy only at 1 year of life. Mother is trained for home-based physiotherapy care. Stiffness improving with physiotherapy, and child is on AEDs. Regarding immunization.
Started from the antenatal
Yes,
history,
ma'am.
so you had started the history prospectively. So then why did you include the seizures, like last episode of seizures, and then again went back to seizures from the 4 months of age? Since you have started the child, the mother noticed the stiffness and the delayed milestones. Better you start the seizures, the mother next is the morbidity, the mother notices the seizures. Starting from the 4 months of age.
Yes, ma'am.
First is the tone abnormality, second is the
Seizures.
Okay, so you can say, you can put it that way. So
Okay.
the mother initially noticed the stiffness, then at 4 months of age she developed, she noted but the baby had seizures,
Sure.
for which the baby was started on any anticonvulsants, and even with anticonvulsants the seizures are not under control. Okay, you can put it that way.
Okay.
Don't go from from the antenatal history and then again from 4 days ago the child had seizures. And one more, can you go to the previous slide? Okay, ideally you are not supposed to say like history of history related to the higher motor functions, history related to credits. Probably this is for the sake of convenience in this presentation, but in exam please don't give side headings to history of present illness. Okay, so just go back. No, history of present illness. Yeah, next. Okay, so you say, put that like the child is able to recognize mother. So what made you think that the child is there? From the history that you are very confident that the child was able to recognize the mother?
Child is looking at the mother when she speaks or something, but there is no social match, just the child is able to look at the mother.
So it's not recognizing. Recognizing is something which the baby understands that she is the mother. But if you are not very sure that the baby, because from the history what you say, the child doesn't seem to perceive anything. Okay, so in that case this alone is probably it's not positive finding.
Okay.
So you better don't stress on it. It's just looking at the mother just like it's looking at any other object. Okay, so don't be specifically positive on this aspect. Okay, next. Yeah, and one more is sensory system. Yeah, so the most important, or other than this mosquito bites, most important is giving injections. The child crying while giving injections. That will be more specific than this mosquito bites or wet diapers. Okay? Yes.
Every time the child cries when the mosquito bites.
No, sir. Immunization history. Child immunized based on national immunization program. Optional vaccines was not given. Regarding family history, is non-consanguineous marriage, no history of recurrent abortions, and no history of intellectual disabilities in family. Is the first child healthy and attending school.
So do you think this is important in this case?
So if it is a consanguineous marriage, it is important, ma'am. This is a non-progressive disorder, but in case some non-progressive disorder can be presenting as CP initially. If it is a consanguineous marriage, some hereditary like Tay-Sachs, Krabbe's disease can initially present as static disorder and can go on as progressive neurological disorder.
First, there is a possibility of neurodegenerative
disorders.
You want to rule out that. Is there any other possibility of this family history related to this your diagnosis?
2% of CPs was inherited, ma'am, and if the first child, if it is preterm or first child, so there is a risk of next child to be born as preterm, and there is
2%
possibility.
of CP is not inherited CP.
It's a genetic.
Incidence of CP is of course 2%.
2 to 3
But
per
all the
thousand.
CPs are not inherited. We don't know, of course, why some children develop CP. Yes.
Okay. Any other reason? Any other way by which can relate this family history and the consanguinity to your present diagnosis? Apart from ruling out a neurodegenerative as a differential diagnosis for your condition, do you think any other it is related to this? This history is important. Can you rule out any metabolic disorder? Do you think can present as a cerebral palsy?
Yes, ma'am. Like if it is spastic diplegia or arginase deficiency or Segawa disease can present as spastic
So you have to
diplegia.
keep that also in mind. Not always it's only a hypoxic insult. It could be a metabolic disorder also. Okay. Yeah.
Diet and feeding history. Child able to swallow only liquid and semi-solid diet. Mother is feeding either in a cup or a spoon or in tumbler in smaller liquids. Child is taking 650 calories, which is again 1200 kilocalories, and protein is only 10 grams, which is again 16 grams. Socioeconomic history. Child lives in a semi-paka house with separate kitchen and toilet and municipal water facility, and the family falls in upper lower socioeconomic class and a modified Kupasamy scale. Parents are aware of the chronicity of illness and need of supportive lifelong therapy. Summary. So 2 years and 9 months old child with global developmental delay.
How do you know? Excuse me. How do you know it's a global developmental delay?
When there is
the history itself.
Yes, ma'am. When based on history, global developmental delays, there is delay more than two or more domains. So there is obvious delay. So I would like to take it as a global developmental delay.
So what other domain you think the child has a delay from the history?
There is obvious delay in all 4 domains, ma'am. From motor, fine motor, sense, social adaptive, and language delay.
So what significant perinatal history do you think could have been attributed to this lesion?
The child first is.
What are the positive histories in the perinatal period?
The child had low birth weight, which is 2 kgs, ma'am. So this could be any possibility of any antenatal insult, but a child did not cry immediately after birth. Adding on to that, detail was not available. Adding on to that, there was a prolonged NICU stay for 30 days, along with a significant ventilation history. Like the child was on ventilator for about 30 days.
So what do you think the probable illness in the newborn period? This child had newborn or in the perinatal?
Since say it is a static encephalopathy.
There is no progression or worsening. There is no progression or worsening of symptoms.
Is there any no progression, or is there any change in the signs and symptoms?
There is actually with physiotherapy the stiffness is improving. So
yes. So even though there are some changes in the signs and symptoms, the disease is not progressing.
The motor and either the motor or movement disorder can worsen, but others actually the spasticity is also improving with physiotherapy.
You are right.
So
but in static encephalopathy, there will be some changes in the signs and symptoms, but it should not be considered as a progressive or degenerative neural disease.
So this child developed respiratory distress from day 3 of life, ma'am. So this could be a possibility of neonatal sepsis also, since the child had an history of lumbar puncture, which was clearly stated by mother. So this could be a possibility of meningitis.
So it had what are all the negative? What are all the positive findings in the histories? One is the low birth weight.
Low birth weight, and the child did not cry immediately after birth, and prolonged ventilation, respiratory distress, and there is a. So this could be either late onset sepsis after 3 days. So the child also had underwent LP. So there could be a possibility of neonatal meningitis, and mother also noted a poor suck and hypotonia during the hospital stay itself.
So neonatal meningitis, or a child born with asphyxia in stage 1 or 2 progressed to stage 3.
It could be anything, sir.
It's also possible, is it not?
Yes, sir.
Yes.
General examination. Child is awake in mother's lap in supine position. Upper limb, shoulder is adducted, elbows and wrists are flexed, hips adducted and extended, knees and angle are extended. There is scissoring and pallor present. There is no icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Vitals, heart rate is 110 per minute, peripheral pulse is normal rhythm, volume, no specific character, no radial or no femoral delay, felt in all peripheral pulses. Respiratory rate is 16 per minute, abdominothoracic. BP was 80/60, measured in left upper limb in supine position. Temperature was 99 degree Fahrenheit, saturation was 100%. The anthropometry, length was 61 centimeters, again 86 centimeters, which was less than first centile. Weight is 4.2 kgs against 12 kgs, which also falls less than first centile. Weight for length is less than first centile. Head circumference 36 centimeter, which falls less than third centile. Mid upper arm circumference 11 centimeter. This is microcephaly with acute and chronic malnutrition.
How did you measure the length? The child is spastic.
Spastics.
So how did you measure the length? Were you able to pull that?
The child was, it was in extended position only. So the lower limbs were in extended position only. So I was able to measure the length. Yes, sir.
Yes.
Head to foot examination is microcephaly, prominent metopic sutures, sutural overriding were present. There is convergent squint in right eye. AF was closed, eye, no evidence of vitamin deficiencies, no cataract or no dental caries. Rachitic rosaries was present, there is bilateral adductor thumb, bilateral scissoring was present, no neurocutaneous markers, no callosities, scars or bed sores, no bony deformities, no contractures.
So what is that? That is a
This is rickety rosary. It was not visible, the patient is there.
Is it rickety rosary or Harrison sulcus?
Rickety rosary was also present, sir.
Also there.
There was a complete head lag when the child was pulled to sit. When the head was held in line with the body in ventral suspension. In axillary suspension, there was scissoring of both lower limbs. CNS examination, child was awake, recognizes mother, irritable with minor stimuli, not interacting or smiling at mother, not interested in surroundings.
See, again you contradict
Recognize.
your own statement. Better you just remove that.
Okay. First cranial nerve could not be
How did
tested.
the child behave to you?
The child did not interact, not.
With the child?
No, sir.
Yes.
First cranial nerve could not be tested. Second cranial nerve, there is not fixing or following a light or red ring. Direct light reflex present. Acuity and color vision not tested. Fundus attempted could not be visualized. Snowtosis, convergent squint in right eye. Concentric light reflex was present. There is no nystagmus. Corneal conjunctive reflex present. Jaw jerk is not exaggerated.
So what about the squint? What is your opinion? It is a paralytic or a non-paralytic?
It's a non-paralytic squint, ma'am. Forehead wrinkling was present while crying. No asymmetry of face while crying. Bilateral nasolabial folds present. There is no drooling of saliva. Child not turning head towards sound stimuli. Uvula in midline.
Did you test the eighth, no?
Initially, I tested by rubbing both the fingers and crushing the papers, ma'am. And
Okay. So what is the important point in any, examination of any, especially the hearing? What is the important?
we should not give and startle. We should
most
not bang
importantly, you are
the.
not supposed to stand in front
front
of
of-
the child. Okay, so this child of course doesn't have any vision, but anyway, you are supposed to stand at the back and then do this testing.
Uvula in midline, gag reflex could not be tested. 11th nerve is tested. Tongue in midline, there is no fasciculations. Bulk is uniformly reduced in all four limbs and is equal in both sides. Tone, there is uniform increase tone in all four limbs and spasticity. Based on Ashworth skull, it comes around 3 to 4. The best observed power in upper limb was 3 to 5 and best observed power in lower limb was 2 by 5. Superficial reflexes was present, and the plantar were the extensor. This video shows the cremasteric reflex of the patient. Deep temperature reflexes was
Significance of this cremastic reflex.
It was present.
Cerebral palsy.
Usually in all upper motor neuron lesions, the superficial reflexes will be lost, sir, except in CP it will be preserved. All the deep tendon reflexes was exaggerated. Ankle clonus was present. There is no patellar clonus. So exaggerated biceps, and this is. Primitive reflexes, asymmetric tonic neck reflex, palmar grasp, plantar grasp, and palmar mental reflexes was present. Moro, sucking and rooting reflexes were absent. This is a video showing the palmomental reflex. Stroking the thenar or hypothenar side, cross puckering of lips and lifting of legs. Sorry. Based on postural or lighting reflexes, parachute reflex and Landau reflex is not present. Sensory system, child cries in response to wet diaper. Other sensory
motor component. What you have missed? What is the important thing? You talked about the bulk. So
yes.
Is it the power? Is it the tone? You told the reflexes. Then?
Involuntary movements.
Yes.
That's right.
That comes as a part of the motor system. Okay. Are there any involuntary movements?
No, ma'am. There is no involuntary movements. And I mentioned in history, ma'am. I forgot to make a mention in the examination.
And about the coordination also, even though for a child
Cerebral
who is not able to understand your commands and this power is just only 3/5, you can make a mention. Coordination couldn't be tested, but you should make a mention that you have looked for the coordination. Okay.
There's no spinal deformities or no meningeal signs. Other system examination, cardiovascular system, S1, S2 was normal, there is no murmur. Respiratory system, bilateral normal vesicular bed sound was here, no added sound. Perineum was soft and there is no organomegaly.
And one more, just go back. We have to make a mention about the microcephaly here also. Okay.
Yes, ma'am. I mentioned in the head to foot.
It's only spine and cranium together.
Yes, ma'am.
Okay, as a completion. So, in the CNS part, you have to make a mention about the microcephaly.
Summary, this is a 2 years, 9 months old child with global developmental delay, seizure with stiffness of all 4 limbs without worsening of symptoms. On examination, found to have microcephaly with bipyramidal signs and persistence of primitive reflexes. Fundus I have mentioned, ma'am, it was attempted but I could not be able to vision. I mentioned. Without worsening of symptoms, on examination, found to have microcephaly with bipyramidal signs and persistence of primitive reflexes. Diagnosis, case of spastic quadriplegia, cerebral palsy, probably due to HIE or other perinatal insults, level 5 functional class based on gross motor functional classification system with microcephaly with vision and hearing impairment, seizures, with chronic malnutrition and rickets.
When you say vision impairment,
the child
is able to recognize a mother and cries on seeing you.
But there's not fixing or following light. There is not. It's not able to fix or following the red ring or toys.
Is it due to visual defect or the child is not interested in your testing?
Or where will you put the lesion? Which
cortical.
level?
It's a cortical blindness.
Cortical blindness.
What about the pupillary reflex?
Pupillary reflex was actually present, sir.
Can you get normal pupillary reflex in your blind child?
Yes, sir, we could.
How? You are right.
The nerves were intact. It's the corticals and the third and second. In the cortical level. Third.
So that's why the cranial
Third
nerves
nerves
are not affected. It's an upper motor
third
neuron
and
release. So, can you
I
define?
think vision is normal. The child is looking around.
Okay, sir.
Testing, the child might not have responded to your light. What is optokinetic reflex? Did you test it?
No, sir. The movement.
Did you check for it?
No, sir.
That should also be done.
Okay, sir.
In a young child, which will not respond to your stimulus. This is involuntary. Optokinetic.
Optokinetic.
Yes.
Okay, so can you
So
define?
diagnosis is cerebral palsy.
Yes, sir.
When will you suspect cerebral palsy and when will you suspect something else other than cerebral palsy? What are the points to suspect other than...
When there is a consanguineous marriage with family history of cerebral palsy, worsening of losing of previously acquired milestones, when there is a regression of milestones,
Yes.
there is worsening of motor symptoms, and that is associated with other symptoms such as like dysmorphic phases, organomegaly, abnormal urine udder.
Yes. Then?
It is associated with any organomegalies or abnormal urine udders.
Yes. Then? Yes. A positive family history.
For-
should make you to think of something else than the cerebral palsy. And as you said, the regression of
milestones.
Previously normal child becoming abnormal. Of course, it's not cerebral palsy. Then
Loss.
Abnormal ocular movements will never occur in cerebral palsy.
Involvement of sensory system.
Especially nystagmus or upward or downward palsies. These are not part of cerebral palsy. And then
involvement of sensory system also.
Yes, very good. Involvement of sensory system. Sensory loss cannot occur in cerebral palsy. Then
and is associated with organomegaly, abnormal urine udders.
Anything else? You said sensory loss. Similarly, there should not be any muscular atrophy. Muscular atrophy also is not a part of cerebral palsy. Yes. And then associated with severe involuntary movements. Usually CP is not associated with
involuntary.
Extrapyramidal
or chorioathetoid CP can.
But usually if there is obvious abnormal movements, you should think of something else than the cerebral palsy. What is the role of pediatrician? Usually cerebral palsy will be discussed by neurologists. This time only we are asked to discuss. What is the role of pediatrician in the cerebral palsy?
In the multidisciplinary approach, pediatrician is the head of the every team, so it should be.
Yes. Why?
It involves neurologists, psychologists, occupational therapy, speech therapy, language therapy, with the primary pediatrician being the head of.
Pediatrician cannot do. Still you consider the pediatrician as the leader.
The primary pediatrician should be coordinating all the therapies, sir.
Now the importance is, see, they come to the pediatricians first. So it is the duty or the responsibility of the pediatrician to pick these abnormalities first and then start the intervention. So pediatricians are given the prime importance. Okay. So it is our duty that we are not supposed to miss any CP, especially we know when the CP becomes a florid like this, anyone can diagnose. But only a pediatricians can diagnose the CP at the early. You have certain early markers of cerebral palsy. That should be identified early. Otherwise, there is no point in discussing the cerebral palsy as a case after the baby has become a florid CP. So what are all the early markers of cerebral palsy?
There is a history of incessant cry, irritability in early infancy, late acquisition of head controls, history of small head size, history of persistent fisting, presence of scissoring.
Fisting beyond which age?
3 months.
3 months, not 3 months, actually through 2 months, 60 days. Okay, then.
Abnormal scissoring, any abnormal tone or ATNR more than 4 months.
Okay, so from the early markers, from what you have listed, it means that the minimum that you can pick up is at 2 months. That is the persistence of the cortical thumb or the persistent fisting. Okay, so even before, do you think can you pick up the CP before 2 months?
Yearly
is there any possibility of picking up a cerebral palsy?
When there is severe spasticity, there can be yearly attainment of head control in few patients. Sir.
It's not head control, it's just a spasticity. Okay. So if there is any tone abnormality even before 2 months, you can pick up. Okay, then anything else? Any other clues to pick up CP early so that you can do the intervention early? So that is the role of a pediatrician.
Okay. Incessant cry and irritability since birth.
Okay. So the cry. And another thing is prolonged feeding. Normally we expect the baby to finish the feeds by 10 to 15 minutes, a normal child, because of the good oromotor tone. Suppose if the baby takes too long to complete the feed, the mother says, I am keeping the baby in the breast for more than 30 minutes, but still the baby is not able to feed properly, the stomach is not full, it means then we have to suspect the baby has some tone abnormalities and you have to look for. Okay. So, and most important is any encephalopathy, features of encephalopathy or tone abnormality that should be picked very early so that you can do the early intervention. So that is the main role of the pediatrician. At the earliest we can pick up, suppose they come at 45 days for the first DPT vaccine. So that is the time you do a routine, a small, very simple neurological examination to find out if the baby has some neurological problem, and then you can start the intervention. So that is the role of a pediatrician. Okay, can you?
Pediatrician is the first person to treat this child with asphyxia. So what are all the strategies will you follow to prevent severe sequelae or complications in an asphyxiated child?
We can take
The child was
therapeutic
in NICU for more than 1 month.
30 days, yes, sir.
Yes.
Initially, when there is asphyxia, like less than, if it is severe asphyxia, we can attempt therapeutic cooling, sir. If
Asphyxia, will the therapeutic cooling help?
sir,
In severe asphyxia.
when there is asphyxia, we can attempt therapeutic.
Studies say it will be useful only in
Mild to moderate, first and
asphyxia.
second stage.
Is it not, sir?
Yes, sir.
Yes.
And we, since there is the worsening of symptoms from day 3 of.
What is the pathophysiology of hypoxic ischemia? You know that you can say.
There is an
What are things you can do in the
if this child had distress from day 3 of life, so this could be a late onset sepsis that could have been prevented.
You could have read primary energy failure.
Primary energy, secondary energy phase.
So what will you do during primary energy failure? What will you do in secondary energy failure?
Initial primary energy failure, proper resuscitation in the first itself will avoid taking the child to the secondary energy failure status.
What causes the primary energy failure? Ischemia, is it not?
Primary hypoxia.
So how will you prevent it? Further ischemia. The child is in the PICU. So you have
Maintaining the
to-
electrolytes,
Yeah.
maintaining the electrolytes, euglycemic
So
values.
that the cerebral perfusion is maintained. Yes. Then
Maintaining euglycemic state, normothermic state,
yes.
and initiation of yearly enteral feeding, maintaining the other electrolytes,
Okay. Then secondary failure will be managed. Is there any strategies we follow in the newborn unit?
gentle ventilation strategies to avoid fluctuations in the cerebral blood flows, to proper control of seizures,
Okay.
and in case of if any to avoid any hyperbilirubia and early intervention of hyperbilirubemias.
What is the role of anticonvulsants, especially topiramate and phenobarbital? How the secondary failure leads to injury to CNS? There will be excitotoxicity and inflammation. So you have to combat. What will you do?
To reduce the excitogenic status of the brain, and so that we will give either AEDs like phenobarbital.
Yes. Anything new has come in to treat secondary failure? New advances?
Or antioxidants can be given,
Yes,
like
antioxidants.
allopurinol,
Erythropoietin and stem cell transplant also.
Yes.
What are the differential diagnoses can you offer for cerebral palsy?
If it is a progressive neurological deficit, if it is spastic quadriplegia, we could offer other neurodegenerative conditions like Krabbe's, Tay-Sachs. If it is spastic diplegia, it could be arginase deficiency, Segawa disease. For atonic, it could be SMA. For atitotic,
Of course, there is a very big list, which nobody can remember. Only we have.
for chorea-athytoid, it could be other movement disorders
Yes.
like Halovidan-Spas disease. And for atasic CP, it could be A-beta lipoproteinemia and other atasic disorders.
You can classify it as cerebral palsy with apparent muscle weakness, cerebral palsy with dystonia or involuntary movements, and severe spasticity with the significant ataxia, like that. We're getting 6 or 7 lesions are there. You go and read it.
Okay, you know the definition of
Yes.
cerebral palsy. Okay, so then you're based on the functional, okay, you are classified based on the functional and the associated comorbidities. You have put it as microcephaly, vision, hearing impairment, seizures, chronic monitoring. Okay, so how are you going to, what are the investigations you are planning to do?
Actually, cerebral palsy is basically a clinical diagnosis, ma'am. For this child, I would like to proceed with CBC because I have noticed pallor in...
apart from the routine examinations, okay. So what investigation, any specific, like CNS specific investigation?
MRI could be, should be done.
MRI in cerebral palsy.
To differentiate it from other progressive disorders, MRI should be done, or if the cerebral palsy's cause is not known, MRI is mandatory. If the mother has not completed her family, we must be able to advise her whether this is primarily due to HIE or antenatal cause or due to any inherent disorder. So we need mandatory to do an MRI.
So now earlier imaging was not mandatory. Now it has been any child with encephalopathy you are supposed to do an MRI. Okay, then any other
necessary to do CT or MRI serially?
No, sir, it's not necessary to run serial MRI.
Is it necessary? You have taken a CT at the newborn period. Is it necessary to take it again or not?
If it is done in the early newborn period, there are few markers which would predict CP, sir. But if there is no changes in the newborn period, it doesn't mean that the child will not develop CP and doesn't mean that the child will not have any further MRI changes. So we should do an MRI after the child developed CP or any signs of cerebral palsy.
Even though initial CP is normal, changes may occur after 2 to 3 years. So there is no harm in taking an MRI, especially at 2 or 3 years. You can do something, especially in cerebral dysgenesis. Lesions will be more obvious by 2 to 3 years. So you can repeat it.
Yes, sir. Yes, sir. CT, if we take CT, we can able to find calcifications. That is a low birth weight also for this child. Yes, sir, it's there, sir.
What type of microcephaly do you think? It's a primary or a secondary?
Could be a secondary microcephaly, ma'am, because due to brain atrophy, there is sutural overloading. So this is a case of secondary microcephaly.
What are the treatment modalities which are available for this cerebral palsy?
It's a based multidisciplinary approach, ma'am. First, we should include our physiotherapy. So we should start an early physiotherapy to avoid spasticity and to abolish primary reflexes to felicitate the appearance of postural reflexes. Then occupational therapy to improve the daily activities of the child. Then vision and hearing.
Physiotherapy, do you think like regular, what is any specific form or any specific modality of physiotherapy, especially for these CP children, so that you make the child acquire the milestones? Do you think, or you do the routine physiotherapy that we do for any other
basically
the early interventions?
The Babot method is the accepted one because it is the physio is based on abolishing the primary reflexes, felicitation of appearance of the postural reflexes, and to correct any tone abnormalities like spasticity, so that it will felicitate the child to do its daily activities as far as possible.
Okay, so that kind of physiotherapy where this, since the primitive reflexes or more, these are the ones which are preventing the child from acquiring the normal milestones. So your main aim should be to
abolish in the primitive reflexes
and enhance the baby or facilitate the baby to develop the normal, and the mother should be instructed properly how to hold the child, what are all the key points where she should not touch the child and where she should touch the child. Okay, so that she doesn't initiate any primitive reflex or she has to facilitate the reflexes. Okay, so the physiotherapy should be oriented in that way, not a routine prevention of contractures. Okay, that is only after few years, but if you want to start early, it should be that oriented. Okay, and suppose if you are discharging a child with this child was discharged at 30 days of life with some neurological problems.
45 days.
Do you think at that time you could have done anything for this child so that this child doesn't have this problem at this time? Or any
yearly stimulation like sensory stimulation, tactile stimulation, visual and hearing stimulation. And if the mother has noticed tone abnormalities, we should inform the mother there is a risk of CP, and we should inform regarding early markers. We should advise her regarding the warning signs of CP and to seek medical attention earlier.
So any child with either hypoxic injury or infectious injury and discharge from the newborn unit should go with the advice of early sensory stimulation. All this the mother should be advised, and you are supposed to do a basic neurological examination to find out the tone, what is the tone abnormality which is present at the time of discharge. So, and if you find any tone abnormality, you better keep the close follow-up of this child, and let us not wait till the child develops any spasticity or any deformities, so that child develop all these complications. Okay, so that is very important. So whenever, just have as a practice, whenever you discharge a child with HIE, you better do the sensory stimulation and the basic neurological examination at the time of discharge and the close follow-up of this children. Okay, what do you think the prognosis?
This child is like 2 years and 9 months, ma'am. This comes around like
So
30.
what is the developmental age of this child?
Developmental age is 2 to 3 months, and developmental quotient is 10.
Okay. So what do you think? What is your what do you expect your treatment is going to do for this child?
We could reduce the spasticity for this child, ma'am, and avoid complications like recurrent aspiration. We can help in, this child is having feeding issues, so we can train the mother in feeding the child, and we could avoid other nutritional, we could improve the nutritional status of the child, so that any pseudo regression could be avoided, like iron deficiency, B12 deficiency.
What do you expect the outcome? What is the expected outcome? What is the aim of your treatment? What do you want to make the child?
Reducing the tone and improving the daily activities of the child.
So make the child as independent as possible to the maximum. Okay. So what all do you think can cause death in these children?
Aspiration, actually seizures and aspiration, but aspiration will kill the child.
And infections. They are more prone for infections, urinary tract infections, septicemia, as well as CNS infections. They are more prone for. Okay, so these are the usual cause of death. And most important is the day-to-day activity. The feeding is the main problem. So you have to instruct the mother how to feed the child to prevent the aspiration.
Done.